Good morning, respected everyone. This is Dr. Simran from Jerbai, Wadia Children's Hospital, Mumbai. So first of all, I would like to extend my gratitude to PCSI for funding this research. The topic of our research was cardiac MRI finding on midterm follow-up in children with myocarditis secondary to SARS-CoV infection. As we all know that the COVID pandemic had the destructive implication or impact on overall global level. With the latest WHO update had revealed that more than 340 million people were affected and almost 5.5 million people had died out of this COVID infection. MISC is an aftermath of infection secondary to SARS-CoV-2, and the pediatric manifestation ranges from acute myocarditis, shock, to Kawasaki-like illness to heart blocks. Though most studies have focused on acute presentation and management of affected children, our knowledge is significantly lacking in the area of natural history and medium to long-term follow-up of such patients. So with this aim to evaluate the cardiovascular finding on cardiac MRI in patients treated for COVID-19 myocarditis on midterm follow-up, we began this study. And the objective of our study was to compare the LV ejection fraction between the cardiac MRI and echo-based parameters, and also to correlate the cardiac biomarkers with CMRI findings. So this was a single-center retroprospective observational exploratory research study conducted at our department in Wadia Hospital, Mumbai over a span of 18 months from 1st March 2021 to 30th August 2022. Total of 19 patients who were diagnosed as myocarditis secondary to MISC were included, and those patients who were known case of CHD and cardiomyopathy were excluded. Their demographic data, cardiac biomarker levels, and echo and CMRI findings were noted. CPK-MB level more than 25 unit per liter and NT-proBNP level more than 100 picogram per ml were taken as abnormal. Amongst the echo parameters, LV ejection fraction and coronary artery dimensions were taken into account. And based on the LV level, it was further graded into various degree of LV dysfunction. Cardiac MRI at follow-up of all these patients were done as per the established myocarditis protocol on a 3 Tesla Phillips MRI scanner. The parameters which were included were native pre-contrast T1 mapping of the myocardium, native T2 of the myocardium, 12-minute post-contrast late gadolinium enhancement, indexed volume of the LV dimensions, LV ejection fraction, and extracellular volume. So this LV ejection fraction was compared between the echo and cardiac MRI. And also we tried to establish the correlation between the MRI-based LV ejection fraction to native T1 and between the cardiac biomarkers to native T1. The data was analyzed using the SPSS2 software, and the comparison of median LVEF by echocardiography and MRI was done using the Mann-Whitney test. And the p-value less than 0.05 was taken as statistically significant. So out of the 80 patients who presented to us with the diagnosis of MISC, 58 patients amongst them were excluded with KD or KD-like illness, leaving the 22 patients with myocarditis. Amongst these 22 patients, 3 patients are still awaiting for the cardiac MRI, and we finally took the 19 patients for further studies. Their demographic, biomarker, and echo parameters were taken, and on follow-up, a repeat echo scan and a cardiac MRI was done. So this is the first image showing how the native T1 calculation was done, placing the ROI in the corrected image. So basically, basically this is the myocardium. Here the putting of the ROI will reveal the T1 values. This is the second image showing the short axis late gadolinium enhancement. This is the normal, how the normal myocardium will look like. And in cases of scarring, we can see that there is hyperintensities in the infraseptal area. This is the color imaging of the T1 value. Normal T1 value would reveal the healthy myocardium, which will be of yellowish color. However, with the increase in the value secondary to cellular damage, the color coding will increase in the grading to orange. This is the image showing the bullseye presentation of myocardial function. So amongst all the patients, 19 patients, majority of our patients were female. The age ranged from 0.43 months to 144 months. CPK value was normal in 3 patients. Apart from that, the highest CPK level was seen as was 1821. NT-proBNP level were raised in all of the patients, and LV ejection fraction at first visit was the least was 23.4 and highest was 52. This is a cardiac CMRI finding stabilization, which revealed the cardiac LV function, which was significantly improved as per the as compared to the previous one, based on the echo. The T1 relaxation time was normal in majority of the patient. Only 3 patients revealed the increased T1 relaxation time. None of the patient had any myocardial edema based on the T2 signal. The extracellular volume ranged from 15 to 58, and scarring was seen in 2 patients. One patient had extensive subepicardial scarring, and another patient had focal mid-myocardial scarring. So we correlated, we compared the LV ejection fraction based on 2 modalities, and it failed to establish any significant difference. Cardiac biomarker were compared with the cardiac MRI based T1 value, and CPK MB failed to establish any correlation. However, we saw a positive statistically significant correlation between the NT-proBNP level and pre-contrast and native T1 value. So the myocardial injury secondary to COVID-19 myocardial diseases can happen in different phases of the infection, such as viral infection, inflammation, or during the recovery. Outcome studies are very limited with diverging conclusion. Adding to the layer of ambiguity, we have limited studies on midterm outcome of MISC. Cardiac MRI is an excellent diagnostic tool, not just the prognostic implication, it has also dividing the pathophysiology mechanisms, like it can reveal the myocardial injury, the edema, the scarring, etc. Our study had a small cohort of 19 patients with MISC associated myocardial involvement. Majority of the patients did reveal significant improvement in the LV ejection fraction. We saw coronary dilatation in 2 patients, and both of which was resolved in follow-up echo. Majority of our patients did reveal normalization or near normalization of native pre-contrast T1 value. This was similar to the study conducted by Barzog et al. This indicates that absence of significant myocardial cell injury and/or early fibrosis, and supports the hypothesis that the cardiac involvement secondary to MISC was more of a form of transient inflammatory response rather than a direct cardiac toxicity. On T2 signal, we did not get myocardial edema in any of the patients, similar to study conducted by Kaplan et al. And it also suggested that the resolution of the acute inflammatory phase was seen. Out of the 18 patients, 10 patients had LV EDV high, and 9 out of 18 patients did have LV end systolic volume index high. However, we do not have any standardized Indian data to correlate whether these values are high as compared to the previous. Also, extracellular volume was we did in 16 patients, but due to the respiratory and technical artifacts, we thought that it is not a reliable inference, and we could not draw any concrete conclusion out of it. Persistent LG was seen in only 2 patients, supporting the hypothesis that MISC is a post-infectious myocarditis without significant cytotoxic myocardial necrosis. CPK-MB and NT-proBNP level versus MRI-based LVEF did not reveal any significant correlation, and NT-proBNP level with a native pre-contrast T1 value did reveal statistically significant positive and strong correlation. Limitation of our study, it was a retroprospective single-center study with relatively small number of population subject. No control limb was included, and due to breath hold techniques, limited MRI sequences we could able to achieve. So to conclude, no significant persistent change on MRI in a majority of the children studied at midterm follow-up between 3 to 6 months post-diagnosis of MISC. The comprehensive CMRI assessment supports the hypothesis that the cardiac involvement during the MISC is a form of transient inflammatory response rather than a direct and potentially persistent injury from the virus. Peak illness NT-proBNP level above 18,000 did reveal an alarming signal to us, and this patient should be followed up. So the clinical implication of the study was these findings may provide early guidelines for follow-up strategies for the patient recovering from MISC, and the patients with higher NT-proBNP level should be followed up more diligently to assess the risk of the persistence of the long-term myocardial affection. Thank you.